Hello, and thank you for tuning in. In this video, I'm going to share a typical day in my life as an anesthesiologist simulating a general endotracheal tube anesthetic. At this point, I am an adult cardiothoracic anesthesia fellow, and I am blessed to have provided anesthesia services to approximately 2,000 patients. The day starts early, and in the cardiac world, even earlier. When it hurts, I check my attitude, drive, and purpose. I wash up and caffeinate. The mornings are typically dark and cool. The air, however, always light and fresh. Prior to setting up, I double check that the case is still on and that I haven't been reassigned. If it has not changed, I proceed. Let's go. I test my machine and set my monitors and suction on the OR table, and I add a shoulder roll or ramp if I suspect it's necessary. I turn to my meds, and I keep my trash can and sharp spin close to easily dispose what I do not need. I read my vials and label twice, because once a medication is given, it can't be undone. Remember that. I then shift my focus to the airway. I test the pilot balloon, lube and stylet the tube to Murphy's eye, inflate the face mask, and lastly, organize my setup. As my perioperative team strolls in during this time, I greet them and try to know them by name, including the housekeeping personnel. When I'm all set up, I lock up my controlled substances and leave to meet my patient. I try to put myself in his or her shoes and understand the anxiety he or she may be experiencing and the effect it may have on him or her. So I bring and exude my confidence. I ask questions and listen. Then, noting the vitals, perform an airway and physical exam. We'll discuss the anesthesia plan, and I will obtain consent. I place an IV if there isn't one already. I apply the pulse ox on the ring finger and assess if it is appropriate to give an anxiolytic. Once we have the green light, we roll to the OR together, and I reassure them the team is going to take good care of them. I welcome them to the OR and point out the OR table. Once on the OR table, we place our standard ASA monitors and explain the reasons for them ahead of time to minimize surprises. In short, we want to welcome and treat patients like loved ones and take pride in it. Next, I note the patient's vitals and pre-oxygenate as early as possible. Claustrophobic and extremely anxious patients may be pre-oxygenated with nasal cannula or simple face mask until a bit more sedated. Once the end tidal oxygen concentration is greater than 90%, we'll induce with suction on, and I'll maintain a low threshold for using airway adjuncts like head straps or pharyngeal and nasopharyngeal airways. When breathing ceases, I first protect the eyes. And when it is time to intubate, I position myself, the table, and the patient to optimize the patient's oropharyngeal and laryngeal axes to visualize the vocal cords. With my blade, be it direct or indirect, I go for it, being mindful of the fragility of the teeth, lips, and oropharyngeal mucosa. I communicate my Cormac-Lehane view, intubate, and inflate the pilot balloon. I connect the circuit, listen for bilateral breath sounds, and assess for end tidal CO2 after a few manual breaths. When all is well, I put the patient on the ventilator, dial in my maintenance anesthetic, and secure the tube. Thereafter, for non-cardiac cases, I place a lubricated temperature probe and soft bite block. I'll also place my twitch monitor, BIS, and cerebral oximeter. Now, I have to ensure my sleeping patient is asleep and that my anesthetics are working. I quickly note the vital signs and ventilator settings and ensure they're satisfactory. And if not, I immediately address them. I then take a couple of steps back and assess my patient, left to right, from the IV pole on the left to the IV pole on the right. So I ask, on the left pole, are my fluids and meds running? Did I give my antibiotics? Further down, is the bear hugger on, and is the temperature appropriate? I look at my patient. Are the arms, head, and neck in neutral positions? Is the face protected? Are the eyes and other pressure points alleviated? Is the integrity of my endotracheal tube and circuit compromised? I see a Foley. Is there urine? And if so, how much? On the right pole, is there anything hanging on it? If so, is it connected and flowing? I then look at the monitor and ventilator again. By the time I've completed this assessment, it's typically time for the surgical timeout, and I'm confident my patient is doing well. I prepare for the incision and take a few seconds to clean up the space around me. During the case, I repeat my left to right assessment frequently. I walk around and assess patient positioning. I eye the surgical field and assess the blood loss in the canisters and pads. I later ask the surgical team for a 30-minute heads up to time my emergence and extubation. This gives me ample time to communicate with my attending and prepare for emergence. I administer anti-nausea and pain medications that do not depress the respiratory drive. At emergence, I dial down my maintenance anesthetic, assess twitches, suction, raise the head of the bed, and reverse the muscle relaxant. And when the extubation criteria is met, we extubate as smoothly as possible. We then transport the patient to the PACU and give report to our nurses. I rinse and repeat until I am relieved for the day, which is an end time that is variable depending on the complexity of cases for the day and the needs of the operating room suite. When relieved, I prepare for the next day, which entails reading up on my patients and catering an anesthesia plan after a discussion with my attending. I wrap things up and finally head home. I leave you with a few closing points. Residency is a wild journey. There will be great days and not so straightforward days. Take it one day at a time. Communication at work and at home is key. Invest in a couple of things outside of work that are near and dear to you, like your health, family, and finances. Smile and do good by your patient. Identify your why, your drive, and purpose. Trust the process and be patient with it. Take care and be well.